In this video, I will demonstrate how I complete a shoulder ultrasound examination. It is important that this process is protocol-driven to ensure a thorough and comprehensive evaluation. My shoulder ultrasound examination is divided into 5 steps, where each step has a checklist of structures to identify. One key to identification of tendon anatomy is to understand bony surface anatomy, which will be emphasized in this demonstration. Once a tendon is identified, the transducer is positioned so that the tendon is aligned in short or long axis. Then the sound beam is directed so that it is perpendicular to the tendon to eliminate anisotropy, and then the tendon is evaluated for pathology. Step 1 evaluates the long head of the biceps brachii tendon. To begin, the patient is asked to place their hand palm up on their lap. This rotates the bicipital groove of the proximal humerus anterior, and the ultrasound transducer is placed in an axial plane on the body. The long head of the biceps brachii tendon is identified as a round hyperechoic structure. Note the biceps brachii long head tendon located in the bicipital groove, identified by its characteristic echogenic bone contours. Because the biceps brachii tendon courses oblique and deep toward the elbow, it is important to angle the transducer so that the sound beam is directed cephalad to eliminate anisotropy. This will cause the tendon to appear artifactually hypoechoic. The normal tendon should appear hyperechoic and fibrillar. Note how rocking or toggling the transducer along the long axis of the tendon produces and eliminates anisotropy. Next, the transducer is rotated 90 degrees to visualize the long head of the biceps brachii tendon in long axis, with the normal tendon appearing hyperechoic and fibrillar. Note that the tendon should be imaged perpendicular to the sound beam to eliminate anisotropy. This is accomplished by angling the transducer along the long axis of the tendon, which aims the sound beam toward the head. Note the position of the biceps brachii tendon parallel with the skin surface. Step 2 evaluates the subscapularis tendon and excludes transient biceps tendon subluxation or dislocation. With the patient in neutral position, the transducer is again placed in the axial plane over the anterior shoulder. This is completed to identify the bicipital groove and the long head of the biceps brachii tendon. The transducer is then moved medial over the lesser tuberosity of the proximal humerus, shown here with the arrow. In this neutral position, the subscapularis tendon courses obliquely to insert onto the lesser tuberosity and will appear hypoechoic from anisotropy. The patient is then asked to externally rotate the shoulder by moving their hand laterally. This maneuver stretches the subscapularis tendon so that it is perpendicular to the ultrasound beam, eliminating anisotropy. The normal subscapularis tendon is now seen in long axis as hyperechoic and fibrillar. With the shoulder still in external rotation, the transducer is rotated 90 degrees to then evaluate the subscapularis tendon in short axis. Note the normal heterogeneity of the subscapularis, as hypoechoic muscle is seen interdigitating between the tendon bundles at the musculotendinous junction. Note how rocking the transducer along the long axis of the tendon causes the tendon to appear artifactually hypoechoic from anisotropy. The ultrasound transducer is again rotated 90 degrees along the long axis of the subscapularis and moved laterally over the bicipital groove. This is completed to ensure that the long head of the biceps brachii tendon is normally located in the bicipital groove, excluding tendon subluxation or dislocation. Step 3 evaluates the supraspinatus tendon and rotator interval. To begin, the patient is asked to place their hand on their ipsilateral hip with their elbow pointing posterior. In this position, the greater tuberosity is rotated anterior and inferior in a location between my thumb and index finger. The anterior to posterior extent of the tuberosity is also shown. In this position, the long axis of the supraspinatus is oblique in an orientation as traced by my index finger. The transducer is placed along the long axis of the supraspinatus tendon, and the characteristic contours of the humeral head and shelf of the greater tuberosity are identified. I find it important to begin anterior to the supraspinatus over the rotator interval for several reasons. First, if the long head of the biceps brachii tendon is visualized in long axis, shown by the arrows, this defines the axis of the adjacent supraspinatus, which is seen by moving the transducer in a posterior direction. Second, it is important to visualize the most anterior aspect of the supraspinatus tendon adjacent to the rotator interval. This is because rotator cuff tears commonly involve this region. As the transducer is moved posterior from the superior to middle facet of the greater tuberosity, the angle between the humeral head and the greater tuberosity flattens out, as one approaches the junction between the supraspinatus and infraspinatus tendons. The transducer is then turned 90 degrees over the humeral head. At this site, the humeral head is round, and the supraspinatus tendon is seen as a uniform layer of tissue, appearing similar to a tire on a wheel. Also note the intra-articular portion of the long head of the biceps brachii tendon at the anterior aspect of the supraspinatus in the rotator interval. As the transducer is moved distal relative to the supraspinatus, the superior facet and middle facet of the greater tuberosity will appear as the tendon fibers normally taper at their insertion. Step 4 evaluates the acromioclavicular joint, subacromial subdeltoid bursa, including dynamic evaluation for subacromial impingement. With the patient in neutral position, the acromioclavicular joint can be identified with palpation of the distal clavicle. The transducer is placed in the coronal plane, and the bone contours of the distal clavicle and adjacent acromion are identified. The transducer is then moved lateral to the acromion in the coronal plane to evaluate the subacromial subdeltoid bursa, appearing as a thin hypoechoic layer. To dynamically assess for subacromial impingement, the lateral acromion and greater tuberosity are viewed in the same field of view. The shoulder is then abducted with the patient's arm elevated to the side under ultrasound visualization. Normally, the greater tuberosity should slide smoothly under the acromion without distension of the subacromial subdeltoid bursa. Pooling of subacromial subdeltoid bursal fluid or snapping of bursal tissue under the edge of the acromion indicates subacromial impingement. Step 5 evaluates the infraspinatus, teres minor, and posterior labrum. With the patient's hand palm up on their lap, the transducer is placed over the posterior aspect of the greater tuberosity, parallel and inferior to the spine of the scapula. The long axis of the infraspinatus is identified, superficial to the characteristic bone contours of the humeral head. Note the echogenic triangle-shaped fibrocartilage labrum, also seen at this site. The transducer is then moved medial to evaluate the spinal glenoid notch, seen as a characteristic concavity of the posterior scapula medial to the glenoid. The transducer is then rotated 90 degrees to visualize the infraspinatus tendon in short axis. It is also important to image the infraspinatus at the musculotendinous junction. Normally, the infraspinatus, including the hypoechoic muscle surrounding the central tendon, is approximately twice the size of the teres minor. The teres minor at this location has a smaller and more superficial tendon. A small and echogenic muscle indicates atrophy. In summary, it is important to follow a shoulder ultrasound protocol, with each step having a number of important structures to image and evaluate. Bone contours help to define the overlying soft tissue anatomy. Once the tendon is identified, it is imaged and evaluated in long and short axis, eliminating anisotropy. These steps will ensure an efficient and comprehensive shoulder ultrasound examination.